Hello, I'm Tony DeMaria, the editor of JACC, here with highlights from the March 26th issue of the journal. It's often been said that the holy grail in cardiology would be the ability to image the coronary arteries without the necessity for catheterization. And of course, computed coronary tomography angiography, or CTA, has offered that ability, although the accuracy of CTA in identifying hemodynamically significant coronary stenoses has not always been perfect and has been limited, particularly in the setting of calcification and stents. And so a number of approaches have been taken to enhance the ability of CTA, such as coupling it with perfusion studies, myocardial perfusion studies, or looking at the attenuation of contrast material as it flows down the coronary arteries. And in a forthcoming issue of JACC, we have a very interesting paper that deals with the transluminal attenuation gradient, the so-called TAG, obtained in coronary computed tomography in CTA, and comparing it to the existing gold standard for hemodynamic significance, which is FFR, functional flow reserve. And so these individuals took a relatively small number of patients, some 50 to 60 patients undergoing cardiac catheterization. They performed FFR under standard conditions. They used standard methodology for coronary CTA, with the exception that they used a 320 imager. And they then looked at the transluminal attenuation gradient by measuring the contrast intensity in the coronary artery in Hounsfield units at 5 millimeter distances down the coronary tree. Now, once they had obtained that relationship between the attenuation of intensity and distance down the coronary tree, they then subjected that to the calculation of a linear regression coefficient. And it was that linear regression coefficient that they compared to FFR measurements. And what they found was that taking a cut point of about minus 15 Hounsfield units per 10 millimeters of distance, that they could get a receiver operating curve that yielded a sensitivity and specificity somewhere in the 70s. What was more impressive, when they coupled the transluminal attenuation gradients with conventional stenosis imaging by CTA, then the area under the receiver operating curve for recognizing hemodynamically significant lesions by FFR increased to 0.88. So another approach, a convenient approach, one that's not too difficult, not too sophisticated, that can help us identify the truly hemodynamically significant stenoses by CTA. Coronary calcification has proven to be a very good method for identifying patients with coronary artery disease and those who are at risk for subsequent events. But one of the questions that has remained has been, how effective is the progression of coronary calcification in identifying patients who are at risk for cardiovascular events? And to answer this study, the investigators from the MESA trial went and examined serial CTA examinations on the patients, a large group of patients within that study. And they divided the patients into those who had no evidence of coronary calcification on their first examination, and those patients who had some evidence of calcification already at the first examination. And in those individuals who had no calcification at all, even a 5 Agatston unit increase in intensity subjected those patients to a higher risk of both heart events and all events, a risk hazard ratio of about 1.4 to 1.5. In individuals who already had coronary calcification, an annual increase in the Agatston score of 300 units, 100 to 300 units, conveyed again a risk for both heart events and all events, and in this case a hazard ratio of somewhere from 3.5 to 6.5, so a pretty significant increase in hazard ratio. So these are important data, I think. They provide another modality, that is coronary calcium screening in a serial fashion to predict risk of events in patients with coronary artery disease. We've entered the age of high sensitivity troponins, and these have been a mixed blessing. In fact, the assay itself being much, much higher quality, but the ability to detect troponin levels even in normal subjects has made recognition of patients with myocardial infarction perhaps a bit more difficult. Clearly, one of the potential roles of high sensitivity troponin could be as a risk factor for events occurring in patients with stable coronary artery disease. And to assess that, a group of investigators went back and looked at the data from the PEACE trial. You'll remember the PEACE trial was a very large trial of ACE inhibition with trandolapril versus placebo. And there were over 3,000 patients in this study, all with stable coronary artery disease. And these investigators then specifically looked at high sensitivity troponin I versus high sensitivity troponin T to see the ability to predict events, either death, myocardial infarction, or heart failure. And what they found was, using the high sensitivity troponin I, that in fact they were able to predict events occurring in these patients, that the levels of troponin I, high sensitivity, in the top quartile conveyed a significant risk as compared to the lower 3 quartiles. And that risk was a hazard ratio of 1.88 for either death or heart failure. The risk was just a tad bit lower at 1.44 for myocardial infarction. Now, interestingly, troponin I didn't correlate that closely with troponin T in this particular study. Now, whether that related to the level of the enzyme itself or the method of analysis remains unclear. Troponin I in this particular study was a bit superior to troponin T. So another relatively simple marker we have at our disposal in patients with stable coronary artery disease in predicting events. And now that we have this high sensitivity troponins available, especially troponin I, and it's measurable in most of these patients, we can risk stratify at least the top 25% of patients. So the March 26th issue of JACC brings forth a number of studies that help our assessment of patients with coronary artery disease. I sure hope you enjoy reading it.